Salgado, and she's going to kind of give a formal introduction.
Hi, everybody. Welcome to the CPPI Seminar Series. Today in July, this was supposed to be the June seminar, but we are so happy to host Dr. Rafael Saenz. He is the Chief Executive Officer and Executive Director of the National Hispanic Medical Association, which represents the interests of over 50,000 Hispanic and Latino physicians in Washington, D.C. Prior to coming to this position, Rafael served the profession of pharmacy as the Chief Operations Officer and Chief of Staff of APHA. And before APHA, he was the Chief Pharmacy Officer at UVA, and he's also an esteemed alum of our school. He co-chaired the Pharmacy and Therapeutics Committee at UVA, as well as various patient care quality committees, and he is driven by his dedication to patient care, developing services that effectively prevented admissions and improved medication adherence and ensured safe use of medications. We are very happy to have you, and we is going to talk to us about reflection on his course over these many years of experience on how we can really advance our profession and get pharmacists to practice at the top of their license. So thank you, Rafael. Welcome, and I'll turn it over to you.
Thank you very much, Dr. Salgado. I appreciate it. I want to thank everybody for being here. And can you all hear me and see me okay? All right, wonderful. So you might be looking at the title and think, oh my gosh, another talk about the versatility of the Pharm.D degree. This isn't really going to be about that. This is going to be more about the way we act within the profession, the way we behave within the profession and in healthcare globally. Not so much in and of itself. We talk a lot, mostly to ourselves. So this is going to be a little bit broader than that. And before I begin, there are some housekeeping things I got to go over. So this session does have CE, and I believe Dr. Salgado and Sydney will be sending you this information as to how to claim CE. So I won't go over that. And I don't have anything to disclose. There's no conflict here. I currently work for a board, so I need to tell you that the views expressed today are my own and not my employers nor my board's, unless I explicitly state that they are. Okay. What we're going to be talking about today is explaining the value pharmacists bring to non-traditional practice setting. I want to discuss a little bit about the pedagogical strategies for fostering adaptability, innovation, and interdisciplinary collaboration in pharmacy students. And I want to reflect on the evolving identity of the pharmacist and how it aligns with broader healthcare trends. And I'm very proud to say that I have one of my former residents and students here with us today, and he is outside of pharmacy now, and I'd love to hear his perspectives on any of this. So as I mentioned, this will not be a discussion about career paths, but rather where I believe pharmacy needs to evolve in order to be more effective in both advocacy and reaching our profession's goals. When I think back on how long we've been chasing provider status and how the PBMs overtook the profession, I can't help but wonder what we could have done differently. And then lastly, during my time working outside of pharmacy, some things have become clear to me that I'd love to discuss, especially with open-minded academic colleagues who might help to further shape my understanding and my thinking. Okay, so we truly are going to embrace the academic, Socratic way of learning and teaching today, and I want to welcome a discussion. Sydney and Dr. Salgado, I would appreciate if you would help me monitor the chat and let me know if there's any discussions. All right, so by the end of this session, we'll talk about which area is a pharmacist uniquely qualified to address? Why is it important for pharmacy students to understand the business of healthcare? And which of the following are relevant healthcare trends currently affecting health systems? So all of this will become clear as we go. A little bit about me. I did my undergraduate work at the University of Houston and then transferred to VCU School of Pharmacy. I think those of you who know me knew very early on that I was probably not suited for direct patient care roles. Not that I was bad at it. I just, that wasn't where my passion was. My passion has always been in the business of pharmacy. And so at first I thought I wanted to be a pediatric pharmacist, and then I learned about compounding, and I wanted to open up my own compounding pharmacy. And then during my very first rotation at Children's National Medical Center, I met a gentleman, the director of pharmacy there, who said, "Hey, I've looked at your CV. I think you're destined for different things." And sure enough, I then attended the University of Wisconsin. I did the 2-year HSPAL programs before they were called HSPAL programs. And I received my master's degree in pharmacy administration. One of the things that is unique about my master's degree is it is a combination of two different disciplines. One is business. I did take MBA courses, and then the other half of that was industrial engineering courses. Why? Well, when you think about how a pharmacy operates, especially in large academic medical center health systems and health systems, the logistics involved and the understanding about how to get drugs from point A to point B, using technology, using automation, all that stuff. The system design is important. So I was really glad to have had that background. And even today, I try to integrate Lean Six Sigma principles wherever I go, even in the association setting. I then went to UPMC, where I always tell people I've lived a charmed career. I did, you name it, I did it. Inpatient practice, clinical practice model design, outpatient ambulatory pharmacy administration. I even manage their international sites abroad. So I have experience in other health system payer environments other than our own. Then it was time to kind of go to that next phase. I went to UVA, where I went in as their inpatient director, and then three months after I was hired, the chief pharmacy officer said, I'm gone. And luckily I got the nod, and I led UVA for the 8 years after that. Had a blast, love it. And it's where Matt Jenkins and I started working together, and now he's the CPO at VCU. Then around 2019, I said, all right, got to go to the next phase of my career. I started up my own consulting firm, and I was doing really, really well. And then COVID hit, right, in March of 2020, and all the contracts started drying up. So what does one do? Look for a job. I had to go back into the practice. APHA had just hired a new CEO. I got a call and said, hey, I'm looking for an operator. Would you be interested in coming to APHA? I've always wanted to work in associations. For those of you who know me, know that my whole career has been suited towards working in associations. However, I did feel like I got to APHA about 10 years too soon, but it was a lot of wonderful learning, and I'll talk a bit more about that in just a bit. And then through several CEOs of APHA, I got a call from a recruiter saying, hey, we have a National Hispanic Medical Association that's looking for a CEO. How do you feel about this? And at first I thought, well, one, I'd be leaving my first love, which is pharmacy. But two, I think it's time for me to really explore some of the questions that I've always had about the profession. For example, why does medicine oppose us on certain key legislation? What is the medical community truly feeling about pharmacy, and how do I get more involved? And more importantly, I've always had this itch to contribute back to my culture. So a little bit about me personally. I grew up in the Rio Grande Valley of South Texas along the Mexican-American border. And I'll tell you, growing up, the only healthcare I got was by crossing over into Mexico. That's what we could afford. That's what was available. And I think I did okay. I'm still alive. But whenever we did have to get help in the US, or medical care in the US for a variety of different reasons, such as schools required proof of vaccination, etc., we would have to get on a bus and travel outside of town and then walk a couple miles to the nearest WIC clinic. Right? So in case you don't understand, WIC is the Women, Infants, and Children's clinics that are part of federally subsidized healthcare for Americans. So that is how I received my healthcare. So I saw NHMA as an opportunity for us to give back, for me to give back to my community and contribute somehow to healthcare and understand more about how pharmacy is viewed. A little bit about NHMA. So it was established in 1994. So when you think about pharmacy organizations, it's not as old as a lot of the pharmacy organizations. APHA being one of the 50 oldest associations in the country. NHMA is a relative infant compared to that. But it is a nonprofit association representing the interests of over 1,000 licensed Hispanic physicians. NHMA operates as a 501c6 organization, much like APHA and ASHP and other nonprofit organizations. However, whereas other organizations represent the entirety of the profession, we exist for a very specific subset of the profession of medicine. Further, although we operate as a C6, the heart and spirit of NHMA operates like a 501c3, which is a charitable foundation. Now, when you saw in the previous slide my title, um, I am in the process of standing up a new 501c3 called the NHMA Alliance. And that will be specifically targeting charitable work in medicine and for the community. And as of January 2025, I just should let you know, this is part of the reason why we had to delay this talk. NHMA was receiving roughly 54% of its funding from the federal government for the purposes of promoting and fostering careers in medicine from Hispanic and Latino communities. Now, you all know what happened January 20th of 2025. We got a call saying, your federal funding is gone. So you got to figure out different ways to make this work. So whereas most professional associations get their revenue through education, webinars, conferences, etc., NHMA relied very heavily on federal funding to promote this very specific niche. So we're in the process of securing new funding, and we're in the process of reinventing our business model, which is a wonderful experience. I'm having a lot of fun, guys. Unfortunately, nobody's paying me just to have fun. But NHMA also serves as the leading resource in the nation's capital. We often get called to the White House, Congress, and other federal government agencies to provide insights into our community and how we can best reach them. We do have 2 legacy programs aimed at developing leadership for public health and private sector boards and C-suite positions. And of course, we provide networking opportunities with stakeholders who impact Hispanic health. Okay. So it won't be surprising to hear that people who become pharmacists have different perspective on the healthcare industry than people who go into other professions. So I've worked with many disciplines throughout my career, and it's always seemed like we had the most important thing in common, which is to care for patients. But clearly, there were issues beyond care of patients that formed a chasm between us. And I mean, why else would we be opposed by the AMA at every single time we make a case for provider status, right? So early on in this role, I took it upon myself to just ask questions. I wanted to be like a sponge. I wanted to be like a funnel, just take in as much information as possible. So largely, physicians have a very positive impression of pharmacists. However, many are unaware of our professional challenges. Like, obviously, they have their own thing. They're not worried about us. Many are not completely aligned with our profession's goals. A lot of times, this has to do with vernacular. What do you mean you want to be a provider? Well, to them, some of them, a provider is a person that goes into somebody's home that provides care, like occupational therapy, or helps them get around, the house or something. So it's not everybody, but some of them. And of course, it varies based on where the physician is in their level of in their profession, whether they're like leaders or whether they're frontline practitioners. And then there's a lack of understanding of our training limits, which limits our partnerships. So they understand that we're good at medicines, drugs, pharmaceuticals. They understand we know how to use them. They don't quite get that we can do more than just that we can look at what a patient is in totality and recommend dose initiations. And so I can tell you, when I explain to physicians, this is what provider status means to us in a term that they can understand, I have yet to hear a physician oppose me or say, oh, no, we don't want that. Most of them say, yes, that's what we would love, right? They have their own issues, right? CMS funding. So a lot of physicians rely very heavily on CMS funding because they work in clinics, they work in hospitals that rely very heavily on CMS funding. So they see recent attacks on CMS funding as an existential threat to them, which is understandable. Research versus patient care foci. So physicians, a lot of physicians, especially those that work in academic medical centers, have a research focus. They also have a need to do patient care, whereas pharmacists tend to really focus on patient care. We do have researchers in the hospital and academic health setting, but a lot of them aren't as dependent on research as physicians are. So that's something that we need to understand about where their mindset is and why physicians are less concerned about pharmacist provider status than their own survival. They also have reimbursement challenges, right? So they're seeing their payment for their services decrease a lot of times because of value-based purchasing agreements and or value-based metrics that they have to meet. So there's little understanding about how a pharmacist can help them in this particular arena. They seem to be in the mindset that they singularly can affect this. And I think this is one of those opportunities for partnership where maybe perhaps we need to explore more. And of course, the workforce. Physicians are facing a significant threat to their workforce right now. This new big beautiful bill that just passed puts a cap on how much student loans can, or how much a student can take out in terms of loans for their education. If you don't know, I mean, pharmacy school is expensive. Medical school is order of magnitude more expensive, at least almost double what a pharmacy school tuition is in some areas. Well, this is the problem because this will deter certain students from going into medicine, right, as a career. And then, of course, that has trickle-down effects because if schools start to see fewer and fewer students go into medical school, well, then they're forced to reduce probably their overhead or their cost to be able to have people afford medical school. And then, of course, that has an effect on the faculty and services and other things that are important to academic institutions. And then our advocacy priorities don't always align. Again, I mentioned a little bit about provider status. What does that mean? Also, we started to do away from provider status and call it sustainable pharmacy services. Okay, so they're also concerned about sustainable medical services. And they're also concerned about the limited number of resources that are brought to bear. We focus very heavily on medication management services and helping patients make best use of their medications. That's great. They are interested in the patient holistically. And of course, PBM reform is one of our top advocacy priorities across all pharmacy associations. So these are things that physicians don't always understand. So in contrast, however, these are AMA's and NHMA's advocacy priorities. So although the business model of the two organizations are different, their aim to advocate for physicians in the industry remain aligned. So not unexpectedly, all of the priorities for the AMA promote physicians. NHMA catapults off of these aims and can focus on cultural aims. I'm not sure if any of you had ever seen the AMA's advocacy priorities before, but when I first read them, I wanted to know more. So I made several calls and I spoke to as many people in the AMA as I could. Fortunately, we have a current and former NHMA board chair who are active within the NHMA. And my epiphany was this. They're unhindered by access to payment models. They are unhindered by endless debates on best and innovative practice models. They do not have to prove their worth to anybody. They are, by the very nature of their place in healthcare, valuable and necessary. So this kind of frees up their advocacy time to focus on patients and their profession as a whole. So you look at AMA, reforming Medicaid payments, defending Medicaid, that's understandable. Fixing prior authorizations. Well, I think everybody on this call understands what prior authorizations are and how burdensome they can be. What I think we need to also understand is the burden that's placed on physicians. And many of you probably already know this, and so please roll your eyes if you like. But physicians see this as something that pharmacy has failed to fix, and they're having to deal with it. Again, educating physicians on how these happens or why these happens is important. Promoting physician-led care. This goes very counter to some of the advocacy efforts that we have. not because it truly is a counter. Nobody is saying that physicians shouldn't lead care, but they see pharmacists' initiation of therapy as a threat because they see it as part of something that's out of our control and we're being held accountable for the outcomes. Well, that's something we need to discuss as a profession. They have similar physician burnout issues, and again, making technology work for physicians. I thought this last one was significantly, it stood out to me. And I didn't understand why it was a major advocacy effort for the AMA until I started to understand that they are diving full into AI. So I don't know if many of you are aware, but there has recently, in the past 6 months, been a bill introduced into Congress that allows for AI visits to be billed, for payment, for reimbursement. So if you think about it, there's been a bill introduced that would allow AI to be to receive provider status or receive payment for their services, and pharmacists have yet to make that inroad. So I think it was challenged, and I don't think it passed, but I think it will make another go round. But physicians are very vested and interested in making AI work for them because, again, we look at the physician workforce. How best do we get to more patients in a more efficient manner than through AI? Call up the office, tell us your symptoms. AI algorithms run what they will. That counts as a visit. It's more revenue for physician offices and firms. So yeah, it's coming. NHMA, on the other hand, we're dealing with workforce diversity, but not so much in terms of getting more physicians. We specifically want more physicians who can help our community. Okay, there are studies after studies showing that the reason people of underserved communities don't seek care is because there are barriers, right? The barriers being, people don't speak their language, they can't afford them because typically people from underserved communities are also socioeconomically challenged. And so we need to figure out a way to have more physicians that look like us, right? And of course, this is harder post, SCOTUS decision that affirmative action and other equity programs, don't need to be adhered to. Promoting health equity, increasing diversity in clinical trials to improve outcomes. We've read over and we learn in pharmacy school that a lot of times there is no data on people from certain socioeconomic backgrounds or ethnic backgrounds. How a drug affects one person is going to be different than it affects somebody who's from a diverse background. Advancing women's health. Again, this is an important priority for us, and it actually is one of those priorities that runs across pharmacy as well. Several large pharmacy organizations also have advancing women's health as a priority. So how do we align? So it's clear that we're seen as ancillary and likely a means to an end. You and I both know that we hate that term. Ancillary it hurts, like it's stupid. But it's been my experience, and again, these are my views, and this is my perspective, that is truly how we're seen. Yet pharmacy is the number one thing I get asked about whenever I meet a new physician, okay, either a physician group or a potential sponsor. I truly did not head to NHMA to advocate for pharmacy directly, but I always knew I'd be provided with the opportunity. So this came almost immediately. I do feel like I'm being studied in a way, like I'm a stranger in a strange land that's being studied. And this is what has worked so far. So how can pharmacists provide value outside of pharmacy? It was important for me early on to align with priorities of other disciplines. So on a daily basis, I meet with various different physician groups. So as much as we have the alphabet soup of pharmacy organizations, there is an alphabet soup in multiple languages for medical associations. And then they're each integrally linked to public health organizations, to nursing organizations, to paraprofessional organizations. Everything comes together in this space. So understanding the perspective of others, understanding what's important to them. The reason I showed you the advocacy agendas is important because to me, it helps me better understand where the conflicts occur. So knowing the limits of our framing. And what I mean by that is, you know, we're framing, right? A frame. So, and I talk about this extensively with my residents, how we see the world, how we view things. My pharmacy school experience really helped shape my frame. I see pharmacy through a very specific frame, as does everybody else on this call. But I don't believe that we have a full view of all of healthcare because we're pharmacists. So we have a view of healthcare that fits within our frame. But healthcare is broader. We don't have the panoramic view. So understanding what our limits are and figuring out new frames to look out of is going to be important. Advocate by not advocating. And Matt, I thought of you when I wrote this because for the majority of my career, I've always noticed that when a pharmacist enters a C-suite, they almost seem to jettison their pharmacy identity. And so many of you might be thinking, well, why? We've been advocating for pharmacists in the C-suite for so long. Yes, it's important. However, I do believe that when you get outside of pharmacy and into the C-suite and start to advocate for pharmacists with other organizations, other professions, it's important for you to be universal. It's important for you to understand what each discipline brings to the table. And by that, you help to advocate in some way, shape, or form for the team as a whole. And that is accepted a lot more than me going to a physician and saying, you know what would solve this? A pharmacist. Yes, that needs to be said at some point, but you can't start with that. You have to understand their perspective, where they're coming from. Otherwise, just like in a hospital, you'll be seen as biased and you'll be seen as not having the full picture. And I welcome the challenge, Matt. You know, I've always liked our dialogue. So, you know, if I'm saying something out of turn, please put it in the chat and invite everybody to chime in. So we need to leverage the whole pharmacy expertise, clinical and non-clinical. Schools of pharmacy, you know, obviously I went to VCU. I think it's the best program out there. Definitely better than Auburn. And so I wanted to, sorry, as they dig on that. I do believe though that VCU prepared me expertly well in the non-clinical side of the profession. Providing subtle education to our colleagues outside of pharmacy is also important. Well, you understand how prior auth works, right? This is what it is. This is how you do it. This is why it exists, and this is what it was intended to do. Subtle education doesn't come across as overtly in your face. And then establish yourself on matters in which pharmacists are uniquely qualified to address. We understand payer operations and relations. We understand why prior auths happen. We understand what's covered and what isn't covered, different types of medication coverage plans, et cetera. The business and barriers of medication access. Why does specialty pharmacy exist? Why are there so many barriers? So all these things that directly impact other professions in terms of their quality scores, their satisfaction scores, all that stuff. We have a unique expertise in this. Now, I'm not sure if we directly teach these things in pharmacy school anymore. It's been a while since I left pharmacy school, but you know, I do believe that through practice, we do become experts in this. And then technology, I think pharmacy and technology go hand in hand. We champion technology at all settings, and I think this is something that most of our healthcare colleagues kind of just brush off and don't quite make a priority. So these are opportunities where I think pharmacists can shine. So I'll admit again that it's been a while since I left pharmacy school. And although I've tried to keep up with current changes, I may have missed a few things. So please bear with me. If you want to roll your eyes again, I get that. But I welcome discussion and education afterwards. So when I was at APHA, I had the opportunity to speak with a lot of pharmacy educators from various settings, various institutions and stages of training. The trend, and I believe the data will support my claim, was a shifting towards non-direct patient care roles. This was likely fueled by frontline stories of burnout and work-life imbalance. So movements like the hashtag pizza's not working brought to light on a national scale how pharmacy as a profession was being overwhelmed by market forces that do not put the patient first. Okay? I don't think anybody here would disagree with that. The same market forces, however, diminished pharmacy as a noble and respected profession by treating us, some of us, like producers of widgets and reduced some practice sites to prescription mills. Further, I think the PBM onslaught of independent pharmacies made ownership less and less desirable to many. So while our profession, it needs to connect more with other professions, there are things that we need to understand and we need to prepare our future graduates for. So for example, increasing trends towards industry positions. These positions have a lot of touch points with physicians and other healthcare providers, right? Helping them better speak to the business of pharmacy, not just the business of their industry, not just not just the business of their particular company, but all of pharmacy. So we're also seeing a trend of graduates not sit for their licensure exams because they're going to these non-traditional roles that don't require an active license. So to me, and I remember Dr. White, when I was in pharmacy school, a pharmacist needs to have a license. It's what makes them a pharmacist. And I carry that with me everywhere I go, Dr. Eugene White. So increasing trend of licensed pharmacists transitioning to non-direct patient care roles. So whether pharmacists in frontline transition to leadership roles, whether they transition practice settings, or they leave the profession, right? For a variety of different reasons, either they become entrepreneurs or they just leave to open up a brewery, right? So you're seeing these trends in pharmacy happen, right, into these non-traditional roles. And the reason people are leaving, I mentioned a little bit about balance, but also it's challenging. It's become a little bit of a challenge to be a pharmacist, to wake up in the morning and say, yeah, I'm going to make this business work because the rules are constantly changing. The laws are constantly changing. There's always a new challenge. Pay, right? So our pay is growing and steady, but the world around us is also changing. And of course, I've had a lot of pharmacy students come to me and say, this isn't what I thought it was going to be. So I don't know that I'm going to be doing this forever. So as pharmacists, more and more pharmacists are transitioning into these non-traditional roles. How do we prepare them to still make them advocates for the profession? And some of these things we just probably can't help, but it's good to think about. But I do believe that every pharmacist can be prepared and equipped to promote and advance the profession in any setting. And so, although I mentioned that it's been some while since I graduated pharmacy school, I have continued to precept students and have had lengthy discussions about the curriculum. Some things that have become clear to me. And again, some of these items may be expressed or taught in class, but from my experience, there's a disconnect between what may be taught in the classroom and how some pharmacists convey their understanding of the healthcare industry. I know there's so much to cram into 4 years of study to become a pharmacist. And quite frankly, not every pharmacist will be engrossed in the management of the business of pharmacy. But not understanding the profession in totality creates lambs for slaughter. So let's take provider status for an example. Okay. So one of the exercises I run through with students and residents is I set up a scenario. The scenario is, what if I paid you a third of a pharmacist's salary? Well, first I established what is your perception of what a pharmacist's salary is. They typically tell me around 100,000. I would just make that up. I said, okay, great. What if I came to you and I said, I'll pay you $30,000 a year just to come into work and verify orders or verify a prescription. That's it. That's it. Nothing else. Would you take that job? Well, no. Why would I take that job? Okay. So what if I told you that in addition to the 30,000 a year, I would have a list of services, right? That if you did those things, your earning potential would then be unlimited. So if you did all those things and you kept people out of hospitals, you kept people compliant, all this other stuff, you did med histories, you did admission, you discharge counseling, you followed up with the patient 3 days after their discharge, all that stuff. And you can get paid upwards of $275,000, $350,000 a year. Would you take that job then? And they're like, oh yeah, absolutely. And I told them, well, do you understand? This is how physicians work. This is how provider status works, roughly, right? I'm not going over every minutia detail about provider status, but basically, this is how it works. And them understanding that that is what we've been advocating for the last 30 years, it dawns on them like, oh, that's it? Yes, that's it. So my next question is, are you learning this in school? Are you getting ready for this? And the answer is always like, no, actually, I never even thought about it. Now, a lot of times these aren't VCU students, right? Because VCU students are prepared. But understanding the business of healthcare, how healthcare works, how other professions do their jobs is important. It helps to set the foundation and stages a new grounds for advocacy. You also need to understand, have a better and improved understanding of the business of pharmacy. Okay. So I talked a little bit about what provider status actually means, but also how do you read and understand payer contracts, right? I don't know how many independent pharmacy owners I've spoken to that say this thing's impossible. I mean, I've read a few PBM contracts in my career, and it's not the most intuitive, not the most easy to understand. These are things that I believe need to be focused on more concretely in pharmacy school curriculums. Now, again, VCU may do this. I just know from personal experience that it is not universally taught. Okay. I remember when I was going to pharmacy school, I had a pretty lengthy marketing class with Dr. David Holford, and he taught me how to be a marketer. And I'm glad because now I oversee marketing, right? I see marketing communications, among other things, for both APHA and now NHMA. And understanding how to do that for not just your organization, but for yourself is extremely important. How to do advocacy. Many times our pharmacy school student associations do advocacy day, or we partner with places like VSHP to do advocacy day. Well, the thing is, there is a skill set that I believe pharmacists need to hone to do advocacy. And if it's an optional activity, not every pharmacy and not every pharmacy student will get that competency. And this is where I believe we need to do a better job. I know other organizations, other professions don't require advocacy, but they're in a place that we're trying to get to. So we need to do the work. Writing grant proposals. Why is this important? Well, again, part of the pharmacist skill set that I believe we need to have is the ability to connect where other professions and other potential champions are focusing. How to read and write grant proposals for sponsorships for funding is important, especially if we go back to the altruistic reason we all became pharmacists to help people, right? And so I do believe that that's a skill set that very few of us have, and one that I know that it's becoming more and more of the reason why non-pharmacy partners come to me and talk to me. Business development, right? Not just selling products, but selling our message. How do we build a business that is sustainable, and how do we assess and achieve profitability? Oh, the spelling there, stop at that. Profitability for our business that we decide to bring up. And this is important because, again, pharmacists are uniquely positioned to be not just patient care providers, but also really good at business. So all the schools I work with send me the same evaluation form. And most of them ask me to evaluate the students based on similar clinically focused criteria. So most often I had to check the box for does not apply or not applicable or not taught, right? Because most of the areas where I teach is in administration. And whereas I believe that for clinical competencies, there's a gradient of achievement for the objectives and goals among students, I see less and less of a gradient for more of an absolute in terms of mastering things that I teach and convey. So not all things, financing pharmacy services, clinical and distributed operations, human resource management, et cetera, are clear and have finite principles. But soft skills that add refinement to one's skill sets are simply not a focus for some students. And I believe they're important because although other professions have similar focus on these soft skills, we need to be concerned with decision makers in other professions that are barriers for advancement. Our profession is judged by the very least of us at any point in time. CMOs don't exclusively interact with CPOs. Every pharmacist has an opportunity to influence. So when you think about, if you're someone who hires pharmacists, or if you're someone who hires people outside of pharmacy, when employers get asked, these are the skill sets that most look for. Okay. I think that pharmacists have a mindset where we can do all of these, but these are skills that if you don't hone them, you don't sharpen them, you won't use them. And so we will fall into just the process, right? So pharmacists are very process oriented, very, very structured individuals. Some of these skill sets require less structure, requires adaptability, flexibility, creativity, right? So how do we position our workforce to do all these things and infiltrate decision makers or people who might act as barriers to us advancing? And I think this is important, and I think this is where I think most schools of pharmacy could use more time to develop. All right. And now for the controversial portion of my talk. So what I'm about to discuss are my thoughts and observations from a career's worth of experience trying to advocate and advance the profession. So my recent experience working with associations has also led me to ask why so many of us are disengaged or unhappy with our professional organizations. It's clear to me that although we try to instill the need for participation in professional organizations, many of us do it because we feel we must, or not because we want to espouse the purpose and mission of those organizations. But even the most engaged among us have limited impact because our efforts only go as far as a next level decision maker. All right, let's revisit some advocacy priorities. These are the advocacy priorities of both the American Medical Association and the other APHA, the American Public Health Association. What I've highlighted in yellow are the priorities where some pharmacy organizations have similar priorities and alignment can be achieved. Some are peripheral or adjacent, or there's implied alignment. But you can see many are just things we don't really talk about in pharmacy. They're not really relevant to us, right? In discussion with other specialty medical societies and associations, these two organizations serve as umbrella representation of values and fundamental tenets of their purpose. So how do we in pharmacy turn our healthcare colleagues into champions for our causes if we are not aligned? Some of these are just impossible to find alignment on, right? So, I mean, for example, I don't believe that pharmacy or any pharmacy organization has any statements on gun violence. I mean, they might have policy statements to the House of Delegates, but it's not a policy priority. Okay. Accessibility and affordability, I think, are something that is secondary to things that we do. Again, how do we create champions of these organizations, these professions, if we are not really aligned with them? Some of these things we have absolutely, I don't believe we have any kind of say in. So, for example, the ceasefire and release of hostages in Israel, Hamas. I mean, surely I'm sure that there is a need for that, but I don't think pharmacy as a profession is prepared for or could even influence anything in this area. And again, this is just the reality of the world. So these organizations have transcended the need to seek payment, to seek respect and visibility as providers. They're focused on care and they're focused on the human good. So this is just something that needs to be addressed, right? This is something that we need to understand. Oops. Further, when you read healthcare literature, there are trends in the industry that I'm afraid we're not preparing for. Universal to healthcare, I don't think I have to dive into the fragmenting policy space. No one knows what our industry will look like in 4 years or what type of thought leadership we will have in our supporting agency. So money is finite. So who will get it? What services will be optional, expendable, a luxury, right? I remember in the recession of 2008, I did have a VP that was overseeing pharmacy services call me into her office and said, we need to dismantle the unit-based pharmacy program. And I said, I looked at her like, what are you talking about? This is like one of the most successful programs we've had. And she looked me straight in the face and without any hesitation said, clinical pharmacy services are a luxury and we cannot afford that luxury today. And that has stuck with me all these years, because I do believe it's one of the most offensive things I've ever heard in my career. And the post-COVID environments has demonstrated that deferred preventative care leads to more expensive critical care. Our population is both aging and sicker at younger ages. Health systems are being ravaged by the eroding business models that are less reliant on inpatient procedures and shifting towards less costly outpatient settings with similarly tight margins. There are disputes among all healthcare professions regarding payments for services. Again, money is seemingly finite, but volumes keep growing and the workforce isn't keeping up. The way pharmacies are paid is currently being reinvented due to the hard-fought battles we have had in the judicial and public opinion courts. But will there be a sustainable panacea, or are we just simply slowing the inevitable failure of the existing pharmacy business model? How many of us are here because of 340B and don't know it? How do we better inform every single member of our profession on these local and global trends in order for us to demonstrate that we can have an impact, right? So these are real trends affecting healthcare, okay? We are seeing now, we live in the era where a drug can be curative of these illnesses, chronic illnesses, right, that we have. And we're seeing that drugs are supplanting procedures as central interventions. We're seeing that the margins for these drugs too are not being returned fully to the provider. We have volume growth that we won't be able to maintain. But I also want to focus a little bit about pharmacy specifically. So medication affordability and pricing. I will tell you that in the time that I've been in pharmacy, we have done a lot of work regarding best use of medications. We've done a lot of work around getting reimbursed for our services and for our dispensing services. But very little time has been spent on actually talking about the affordability of meds and pricing and how pricing happens, because we benefit from some of those practices. Then 340B. So there is a significant amount of confusion around 340B. And this is, I will tell you, this is one of those areas where I have had medical associations calling me, asking for my opinion on and discussion around 340B and how they should be framing their policies. Well, please understand that my perspective is from the Chief Pharmacy Officer of academic medical centers, where I can tell you I've studied 340B extensively. Nowhere in the 340B statute was it ever intended for price decreases to be directly transferred back to a patient. However, every single person who opposes 340B points to that being the singular biggest bastardization of the program ever. Even though nowhere in the statute does it ever say that cost savings should be transferred back to a patient. It is specifically meant for a providing organization, a qualified entity, to recoup some of the expenses that they have made into providing greater access and care to their community, right? Because they take care of disproportionately larger percentages of indigent patients. So the thing is, pharmacy directors all over the country have utilized 340B to help grow their health systems, right? VCU is one of those institutions. I know because I've worked extensively with VCU. So the thing that we need to understand too is that the people who are in this webinar right now, many of you are likely here because of the 340B, the 340B savings and the opportunities that 340B has been able to afford the VCU enterprise. Not knowing the books, I can't comment, but I do know that a lot of times when you have academic medical centers that align very closely with universities and specifically schools of pharmacy, there is always some type of agreement between the two organizations where one funds positions in the other. And so 340B is a big engine of that. So if it went away, think about the size and the scope of your program. There'd be a lot of people who would be affected by this. And so helping every pharmacist and even pharmacy student understand the nature of 340B and how it can be leveraged for the common good is important. Medical associations are coming to me saying, hey, why doesn't pharmacy share the revenue of this? Or why is pharmacy not providing better prices? for patients, this is where the education comes in. This is where we need to start to talk to medical associates about how and what 340B actually is and how it's affected and how patients benefit, if not through direct price concessions, which is not true because a lot of times Medicaid programs have pricing pass-throughs, but nobody knows that. They think that we're just eating the margins, that we're charging patients more so that pharmacy can look good on paper. And that's just not the case. So helping understand 340B, helping your colleagues in nursing and medicine understand 340B is critically important. So here are just some observations and areas of improvement. So we do talk a lot, mostly to ourselves. Okay. So I do have a criticism of the profession, and again, this is an academic space, so I feel very comfortable saying this. But I do think that when we talk about practice models, when we talk about reform, when we talk about advancing the profession, we're always talking to each other and we're all agreeing. And I think that this is one of the places where we go wrong. Pharmacy needs to have a forum that invites other professions to buy into the wonderfulness it can do for society. And I believe that that's something that we just don't put a lot of thought into. So we focus on money almost too much. And I'm guilty of this, right? So I've grown pharmacy programs. I've made revenues, lots of money for organizations. And I used to lead with that. And you know, it's understand money makes the world go round. So this is how I got resources, how I grew my department. But to others that are focused on patient care and that are focused on greater societal good, you know, for whatever reason, it's almost too much. They almost kind of disengage. We are highly regulated and often rigid because we must be. But because of this, pharmacy is often seen as the adult in the room. Like, oh, we can't do this. We can't take care of this patient because there are laws, there's rules, there's regulations, and we can't provide patients their needed meds. And I think back to the CMO at an organization I used to work for that used to hand out EpiPens to anybody who would go into the ED and not jot it down in the EMR. He would just come to the table and say, "Hey, here, take this EpiPen with you. You came in for an allergic reaction. I want you to have this." And we would lose the money because we couldn't bill for it, right? We wouldn't be compliant with the dispensing of medications per our board of pharmacy. But to him, he was doing the right thing for patients. For us, it was like, you're doing something wrong. You're doing something bad. You shouldn't be doing it. And so that created a disconnect. Interdisciplinary is good. Working with other professions is good, but interpersonal is better. One of the things that I've learned is that learning how to relate, learning how to listen to the needs and wants of other professionals is important. I've been guilty, and maybe perhaps it's just a Rafael thing, where I come into a room and I'm like, I got nurses, I got medicine, I got therapies, I got everybody here. We're going to make a decision. And the thing is, everybody has their own unique needs, their own unique wants. And to me, it was always about the business and not about what each individual in the room wanted and what their profession demanded of them. So we need to teach the practice model we want to be in and the one we're currently dealing with if we want to change. So if we want provider status, what does that mean? Are we teaching our pharmacy students how to work in a practice model where we are providers and can bill for our services? Otherwise, what happens if one day it just happens? Then what? So we need to be where the patients need us. And this can be inconvenient at times. I used to be guilty of saying, part of the reason the pharmacy doesn't get what they want is because we only work 8 to 5, Monday to Friday. And the thing is, as I've matured in my career, I understand the need for balance. I seek jobs now that have balance, and I welcome and I applaud anybody who has balance in their roles. Medicine and nursing are some of the professions that if you don't understand how they work, they have very wonky schedules. They go where the patients need them. And not to say that we don't, but not every one of us does. And I think one of the criticisms that I've gotten from my time at NHMA is I love pharmacists. I just wish I could rely on them on evenings and weekends. And to me, it's like that's been one of those pieces of dialogue that I've heard my whole career. And quite frankly, um, I get it. I understand why. I didn't go to pharmacy school because I wanted to work 24/7. I went to pharmacy school because I wanted balance. Pharmacy is lucrative, right? Holistic patient care and advocacy often is not. When you think about some public health professions, public health advocacy groups, they're struggling, right? They fund their work based on the altruism of others. Pharmacy has built-in mechanism for making money, and I think that's great. But also the mechanism, the decision makers that be want to take care of patients holistically, and we need to consider that. So uh, we if we keep doing things the same way and expecting different results, well, some people will consider that to be insanity. So clearly we need to change. So what can we be doing differently? Pharmacy advocacy serves to assure the sustainability of the profession, elevate our authorities and place in healthcare, but is being overshadowed by the advocacy agenda of other disciplines, right? Interdisciplinary and interpersonal approaches need to be considered. So integration of medical, nursing, and pharmacy curriculum, perhaps, joint national conferences, or connect pharmacy to larger advocacy efforts, right? So I don't know what pharmacy advocacy for, responsible gun ownership looks like, but I do know that it does affect some of our workforce. And then trainer approach, perhaps more of a focus on soft skills, create business of pharmacy experts, and then graduate advocates that understand healthcare in totality. All right, subsequent questions. Teresa, I don't know how we're doing time. I think we're at time. So which area is a pharmacist uniquely qualified to address? Answer is B. Why is it important for pharmacy students to understand the business of healthcare? Answer is B. Then which of the following is a relevant healthcare trend currently affecting the healthcare industry? C. All right. I hope you all learned something. I hope, thank you for listening to my, my presentation, and I appreciate any feedback.
Thank you so much,